Welcome to the Medical Collective, your go-to podcast where medicine meets real life. I'm Dr. Keisha Davis, a pathologist, personal trainer, and your host. I will be joined by a vibrant team of doctors who are not just healthcare professionals, but artists, fitness enthusiasts, and advocates for change. Each episode, we dive deep into the world of medicine, from untold stories of the healthcare industry to the latest in medical advancements. We're here to bring your insights, answer your burning questions, and explore the art and science of healing. So let's get started and step into the world of the Medical Collective. Welcome back, everyone, to another episode of the Medical Collective. I have a co-host with me today. I am your host, Dr. Keisha Davis, and Dr. Sharon Smith is here, but I'm going to be interviewing her because she did a mission trip, and it's so important that we talk about it. I want to know myself, what does it really mean to step outside of your daily practice, to give care in a setting with limited resources, where you haven't been before, where you don't have your state-of-the-art technology to guide you, and it's just you and the patient. And Dr. Sharon is going to share that with us today on her recent trip to Kenya with Hands for a Cause. So Dr. Sharon, I'm glad you're back. This is going to be a great episode. So tell us a little bit about where you went.
So I went to Kisumu, Kenya. I went with an organization called Hands for a Cause. The founder and CEO of that organization is Dr. Kiana Nix.
Dr. Kiana Nix.
Dr. Kiana Nix. She's a pediatrician and practices in the DMV area. That's what DC, Maryland, and Virginia area. She had been doing mission trips for the past at least 10 years. And
wow.
I've known her now for at least a good portion of that. I think we'd met on Facebook in a physician group, and I think I physically met her in 2016.
Oh, wow.
Yes, she came to Houston. We physically met in 2016. And then we've just connected and been friends, ever since. And I kept telling her, I'm going to come. I want to come on a mission trip. I want to come. And I'd watch her, with her work and what she's done in like Uganda and Ghana, Sierra Leone, and, multiple places. I mean, this trip to Kenya, I think, was her 7th trip to Kenya.
Oh, wow.
So she's been like, this is her. This is what she does. Right. So I finally, I think earlier this year, she called me. She said, I started my separate organization. She's like, I still support other organizations. And I'm planning a trip to Kenya. She's like, the Rotary Club of Kisumu, Kenya, invited us. So we were invited by the Rotary Club in Kisumu, Kenya. So, we did all the logistics, that's needed for the trip. And she did that. That means she has a whole team of people who they've been doing this for a long time. I'm the newbie on that team.
Wow.
Yes, I am the newest person on that team. So, I flew from here to DC, met the team in DC, and then we flew from DC in transit in Europe to Nairobi initially, and then we made our way to Kisumu, Kenya.
So how did you get there from Nairobi?
We flew.
Okay.
We flew on Kenya Airways, Kenya Airlines, and it's literally less than an hour flight.
Oh, okay.
Literally. Like, I went up and came down. That was it. Right.
Okay.
So we got to we got to Kisumu. The first day we got there, I think the first day we got there was a Sunday. The Saturday night, the Sunday we went to church. They invited us to church. So we went to the church service. And like the congregation prayed for us and things like that. And it was great. And then after that, we toured the facilities where we were going to be working starting the following day. So we worked out of two clinics in Kisumu. One was Magosi Health Clinic, and the next one was Ojala Health Clinic. So they're in two different districts in Kisumu. So that's where we did the mission portion of the trip. Mm-hmm. And that was great. And then even beyond that, once we after the days in the clinic and working and seeing patients, we did a portion a day where we gave back. We went to Lutheran school for the special needs, and went back to the church with the kids, and the maternity ward at the Kisumu Regional Hospital.
Oh, yes. And when you're describing the maternity, describe like what the city was like and going from there to this hospital.
I'm not understanding the question. What city?
Oh, did it? Okay, pause this, Sean. Oh, describe Kisumu, because you didn't. Yeah, describe what it was like in the surrounding.
So Kisumu is a major city.
Okay.
Yes, it's not described as particularly rural. Right? Okay. It's not rural. It's heavily populated, but still resources are limited in terms of physicians, medicine, adequate clinics and things like that. This is a population that heavily depends on USAID. And I discovered that when I was touring the clinic on the Sunday after church, right? Because they had like the USAID signs thanking the American people and thanking everyone. This is supported by USAID. We are so grateful and thankful. And I'm like, and then for me, that was just for me alone started like a conversation piece, because with the dismantling of USAID here, my question then was, how is this affecting your clinic, right? So for one of the clinic, they told me they were closed from about February until April. So imagine now, then you have a community where physicians are not working, the clinic is closed, so people are not earning money, right? Patients are not being seen. Wow. So what gives in a community that already have limited resources, right? The other clinic told me that they were not closed, but they did have limited resources, and they told me, we were there in July, and they told me we were not able to order medicine from February until July. Imagine, right? So treatment for some conditions, there's just none.
Can you describe a little bit of the clinic, like what was available? Because you did share before, and I was surprised at the clinics. Like I know they're not the same as some of the clinics we have here in the United States, but what was the setting like, and what did you have to work with to see the patients?
So the settings compared to what we have here is bare bones. But you know what? These people are so resilient. They taught me. We exchanged information and education. They taught me things that I never knew. For example, I was about to see a patient, and I'm asking for a Doppler. So a fetal Doppler is what we use to listen to the heart rate. So I had a volunteer. She was a medical officer. So she left the room and went to get a quote unquote Doppler. What she brought back to me was a fetoscope.
And what is a fetoscope, Dr. Sharon?
A fetoscope is an instrument that it looks almost like a horn, so to speak.
Oh, wow.
So you put one side of it to the abdomen, to the belly, and the other side you put your ear over it, so you're able to hear the heartbeat. Yes. It has limitation because you can't really detect the heartbeat below 20 weeks. So when I saw patients below 20 weeks, I didn't know if they have a heartbeat or not. It was just no. Ultrasound was not available, right? And in some places limited, right? They would have to get an ultrasound another day, right? Whereas for me, what I'm accustomed to, I walk in and see a patient. If I need an ultrasound, grab the ultrasound. I have a Doppler in my pocket. I can, listen to the fetus anytime, and it works. The Dopplers that we use here typically work from 12 weeks on. So 20 weeks, I don't have to worry about hearing, or not hearing, fetal heart rate, heart tones, with a fetoscope. So those were limitation. Another limitation is we typically would measure the fundus, which is the height from the pubic bone onto the top of the uterus, and it usually corresponds to gestational age until in a primate, maybe up to about 36 weeks, 36, 37 weeks, where the baby settles down into the pelvis, and sometimes it's no longer really truly accurate after that. There was no tape measure to be had. So they taught,
wow.
yeah. So they taught me how to use my fingers, like my fingers, and put it on the top of the uterus, the fundus. And if it crosses, or if there's a certain amount of fingers left, then you subtract and you're able to get the gestational age. So when I saw someone who's pregnant, like I saw initial pregnancy, someone who's coming the first time for their prenatal care, and I couldn't date them. I didn't know what the dates were, and they didn't know what my cycle was in March. I'm like, do you have a date in March? Have no date in March. So then I'm like, okay, so I'm counting 40 weeks from the beginning of March to whatever the time that 40 weeks. And I'm like, okay, she's due sometime in this month with no exact due date. Right. So those limitations. They even brought a patient to me who, when I checked her date, went through everything, and she did have an ultrasound at a certain point in the pregnancy. She was like near 44 weeks pregnant. I said, how is this possible?
Oh, no.
So I'm like, she needs to be induced, right? 44 weeks. So we transferred her to the regional hospital for her to have her baby. And I understand that happens a lot. So you get a lot of meconium stained amniotic fluid, aspiration of meconium. I mean, yeah. So those are some of the limitations that I've seen.
You also saw some things at the hospital, right? So the hospital is different than here, where it's 1 to 2 sometimes birthing persons per room, things available to help you. What was the hospital like there?
So the hospital is an open ward. And when I got there, I asked, well, how many postpartum moms do you have? They're like 57.
In one room.
So imagine a floor of beds and 57 people on the floor, and some of them had 2 people to a bed.
Oh, wow. 2 people to one bed?
2 people to one bed.
Oh.
Yes.
Wow.
Yeah. Right. So, this is what I said when I was leaving. I'm like, I didn't know what to expect. So I was just a blank slate. I knew there were communities in need, and how or what specifically was the need, I wasn't sure, because I had never really gone before. Like, I've been to the briefings and the meetings for Hands for a Cause over the months before we went. So that was a good thing. But honestly, if anyone's planning on going to a mission trip, check your biases when you board a flight to leave. No, I'm seriously, seriously, because I mean, even for ourselves, sometimes there were lack of running water. We carried like a case of water for ourselves, for the team, daily meals, snacks. None of that was available to us. And even with our water, there were patients there who asked us for water. We gave them.
You mentioned that about a patient that was pregnant and only had access to water a couple of times a day, clean water.
Twice a day.
Mm-hmm.
She came in, she was dehydrated. She had a headache. I recommended paracetamol, which is acetaminophen. Okay. And hydration. And I gave her some water. And then I'm like, because I asked her, how much water do you drink per day? It's like virtually none. Virtually none. And so I asked her, how is that? She has access to water twice per day. So then what she had to do, I told her, you have to procure your water twice a day, boil the water, and you have to at least keep 2 liters for yourself to drink on a daily basis to decrease your risk of being dehydrated.
Mm-hmm.
Yeah. But the things we take for granted, yeah.
Hello, listeners. We want to remind you that you can catch The Medical Collective on all your favorite podcast platforms. That includes Apple, Spotify, and YouTube. Be sure to hit that subscribe button so that you never miss an episode. We're also on Libsyn, and you can find us on all social media platforms as The Medical Collective. Do you have thoughts or questions? Please don't hesitate to reach out. We love hearing from you. Now let's get back to the conversation. And electricity too.
Electricity also, drinking water. Like I couldn't drink the water there. We used bottled water all the time. And even when I'm showering, trying not to get
water in your mouth.
Water in my mouth and my eyes. I'm like, I need goggles to shower.
Oh yeah.
I need goggles to shower.
I didn't even think about that.
Right. So, I mean, I would encourage, anyone to go on a mission. And I've been threatening to do this for like forever. Mm-hmm. And just finally, the stars aligned and just, I think transitioning to locums, working in a different way, afforded me to be able to take that time. It's very hard for you in private practice for you to say you're going to take, a week, 2 weeks off to go on a mission trip and then take some time to just relax for yourself. Yeah, that doesn't come like that at all.
Wow.
Right. Yeah.
Is there any moment that you still remember to this time that really stays with you about your experience?
Oh yeah, I have a lot of moments that stayed with me. I had one person that I diagnosed with malaria.
Oh.
She came in with fever. Yeah, she had malaria. Did a malaria test, and then this is another thing is that they give malaria prophylaxis to the pregnant women, and the malaria prophylaxis program has been dismantled because of USAID. So they really depend on USAID to take care of the community. They fund the clinics. I mean, yeah.
Wow.
So malaria in pregnancy. And I'd seen malaria in pregnancy once before when I was in residence, when I was in training. But this was like my second time seeing malaria in pregnancy. Right. So that stuck out to me. The fact that people can't afford medicine. I had one person who could only afford 2 days of his antibiotics for UTI. Right? We were literally dispensing medicine out of suitcases and boxes.
Oh, I do remember you sharing that.
Mm-hmm. Yeah.
Wow.
So, but I mean, it was a great experience overall. This was my first one. This will not be my last one. I do plan on going back. And at least giving back that way. And yes, I do give back here in the United States. I am based here, and I've done charitable work here within the United States. I will still continue to do that, because that's one question that I've gotten. Well, why don't you do it here? I do. I've done it. I've never. This is my first time giving back abroad, and I'm a citizen of the world. And if you think we're not intertwined in what happens, elsewhere does not affect us here, well, then just think back about COVID-19.
Yes.
SARS-CoV too.
So true. I think it's so
Yeah.
important. So the role that USAID and other United States funding plays in these areas, can you briefly touch on that? Because I know you mentioned it before with the USAID being cut or a danger in these places. What role does it play? And then I think also, as you mentioned, people like you and Hands for a Cause help a lot to come in and provide guidance and support.
So USAID provided a lot of support, and I could tell that just from when I went and I toured the clinic, right? Because they had the USAID posters all over. Even the prescription pads were stamped with the support of USAID. So that was the first thing that kind of entered my mind, is what is what does this look like with the dismantling of USAID? And actually, I think even with the dismantling of USAID, they will depend even more on organizations coming in and supporting their community, right? Because when we went there, I mean, we bought medicines. We bought medicines from donations, from the donations to Hands for a Cause. We took so many different things, even Pedialyte, Pediasure.
Wow.
Things like that. When we went to the Lutheran school, we bought bags of beans and rice to donate, things like that. So with dismantling USAID, your malaria prophylaxis program is gone. The HIV prevention and treatment program is gone. And I actually even read an article, maybe about a week ago, of a discordant couple. One has HIV and the other one doesn't. And the way they prevented transmission was through the PrEP prophylaxis, right? And condoms. Guess what? Not available anymore. Not available.
Wow.
And actually, what I was told when I was in Kisumu is on the route for truckers. So it has one of the highest incident of HIV in Kenya. So you dismantle the program in the area where it's needed. We know what's going to happen.
Yeah, I was listening to a story about some of the programs for children, the children that actually had contracted it from birth, and how many of them now, some of them were very sick. They have lost a couple of lives because of that. They had to ration the amount of medication they could give them. It was sad.
I mean, you can't ration HIV medicine.
No.
How do you do that? If you're inadequately treated, then you don't have true prophylaxis. That's not how that works.
Yeah. It's sad. Well, I'm glad you went. I'm ready to go. And I think a lot of doctors or people that are listening, would want to know the benefits, to a physician who volunteer, because you've got to find the time. But I think, it truly will rekindle your purpose in medicine, right? You mentioned how you got a newfound perspective on appreciating the things we have, reconnecting with why you entered medicine. donating and the things that it does. So even though it's not a selfish thing, I think it does in a way kind of rekindle the purpose of why we practice. How did it feel for you?
So for me, I did have like a renewed sense of purpose. I felt like I was actually doing something and making a difference where it was so needed. Right? It was just so needed. And educating, right? I'll tell you of one situation where I was able to educate. Like I saw a postpartum patient, and she's 20 years old, and they wanted me to screen her for cervical cancer. I'm like, why? She's 20 years old. And I said, I understand this is not America, but the recommendation in America is from 21 years old. And this screening was me taking a look at the cervix, right? And also with that, they'll do HPV check. I said to them, if I look at the cervix and I see a visible lesion, she has advanced disease. It's no longer screening. That it's advanced disease. If I can see a lesion with my naked eyes,
they just didn't have the labs
screening.
available to do PAP.
Yes, they don't have the labs available to do PAP. So the resources for just even general screening, actually only now they're starting like a HPV initiative. I had the pleasure of meeting the Mrs. Nwango, the governor's wife in Kisumu. And I have a pin that she gave me, where they're starting HPV vaccine.
Oh, good.
They're starting to recommend vaccine, HPV, Gardasil vaccine for cervical cancer prevention.
Yes. And for everyone, the HPV vaccine prevents cervical cancer. 99% of cervical cancers are HPV related, and this vaccine is effective. Yeah. Wow. That's so nice. So has it changed the way you approach your practice? Are you going to use fetoscopes now to check heartbeats, Dr. Sharon?
No, I'm not going to use fetoscope. I'm going to go back and I'm going to use my Doppler like I've always done.
Are you going to use your hands to measure the fundus?
I have. Since they've taught me that technique, I have used it. I did learn a few things, and the people were so nice. Mm-hmm. I ate all their local food.
Oh, good for you.
It was so delicious.
Wow.
Yeah, it was just great. So, I ate a lot. I saw, it was their local food was really was great.
Well, I love your story. I know we'll speak about more of these stories. Is there something final you want to leave with the audience, Dr. Sharon?
I know with the dismantling of USAID, it really hit home in communities that really need it. And if you think, well, it's happening to them, it's happening over there.
Yes.
And it's not our problem. Well, we're global, right? And I always refer back to C19, right? So if you're dismantling programs, if you're dismantling research programs, in foreign countries that give information to us, like on emerging diseases or statistics, or, this area has a particular problem. We have to, put our resources here and help that community so we don't transmit that problem and make it bigger and have it go elsewhere, right? Mm. If you think it's a them problem and it's not a us problem, you really need to think again, right? And I know we're living in times where, everything is costly. Food is high. Gas high.
Mm-hmm.
Everything is high. Clothes high. Everything is just incredibly expensive. If you spent $5 5 years ago, you're going to spend triple that today because that's what I'm seeing. Okay. So it's a shock for me. However, if you can find it in your heart to even donate something to an NGO like Hands for a Cause or other organization that go into these communities and help, because the donation do, we bought medicines.
Wow.
And even things we donated ourselves, we paid for them ourselves. Like I was going shopping, everyone took an extra suitcase of things to donate.
Wow, that's nice.
Yeah.
That's nice. And I think when you got there, you had said you didn't realize there was something else. They were in hospital gowns. Was that it? It was something you mentioned.
Yeah. So, I was in private practice previously, and I was going through some stuff for my office, and I saw the gowns. I'm like, oh, I can take these gowns with me and donate them because I know we were going to the hospital. So that's what I did. I packed them in my extra bag, and we donated them to the hospital. I donated them to the hospital. In addition to that, we donated like personal care items, to the hospital. So that was great.
That's nice. So nice. And Hands for a Cause is the name of the organization you went with. I'll make sure we put that in the show notes if you want to donate or you want to volunteer. Hands for a Cause information will be in the show notes. I think the takeaway is that global mission work saves lives abroad, and we are not in this world together. I agree. We are global. People from around the world live in the United States, and we travel to these places. So we owe it to our duty not only to help locally, but to help internationally. It sustains purpose. It helps physicians, I think, too, in our practice and in our well-being, and strengthens health for all. So stay tuned, everybody, for the next episode. Thank you, Dr. Sharon. This was great.
You're welcome.
All right, take care. Thank you for tuning in to The Medical Collective. We hope today's episode has left you with valuable insights and a new perspective on healthcare. Don't forget, follow us on social media for more updates and behind-the-scenes content. I'm Dr. Keisha Davis, and it's been a pleasure to share this time with you. Stay healthy, stay informed, and we'll see you in the next episode, where medicine continues to meet real life. Please note that the content provided in the Medical Collective podcast, including text, graphics, images, and other material, is for informational purposes only. The content is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with any questions you may have regarding a medical condition. The views and opinions expressed on this podcast are solely those of the individual authors and guests and do not represent those of the Medical Collective, its staff, and any affiliated entities. The appearance of content on the podcast does not imply an endorsement. Neither the host, Dr. Keisha Davis, the co-host, or any guest of the podcast bear responsibility for the accuracy of the content provided or the use of information received through the podcast. Reliance on any information provided by the Medical Collective podcast, its employees, writers, or guests is solely at your own risk.